So I want you to picture, just for a second, a microscopic, like incredibly complex biological filter.
Right.
Now, imagine you have about 1 million of these tiny filters packed into a space roughly the size of your fist. And you actually have two of these fists, sitting right against your back muscle.
Yeah, your kidney.
Exactly, your kidneys. And those million tiny filters are called nephrons. And here is, the most crucial, totally uncompromising biological reality we are starting with for today's deep dive. You are born with your entire lifetime budget of these nephrons.
That's it. That's all you get.
Right. And once they're destroyed, they do not grow back. Like your liver can regenerate, which is amazing, but your kidney tissue just doesn't.
No, it really doesn't.
So today, our mission for this deep dive is to explore this silent attrition of these filters. We're looking at chronic kidney disease, or CKD, from the angle of the slow loss of filtration.
Which is such an important way to look at it.
Yeah, because we want to understand not just what it is, but how it quietly reshapes the whole body, the stages of how it progresses, and honestly, this massive medical controversy surrounding how we even define when those filters are failing.
It really is a fascinating history because, it is a fixed anatomical budget. From the day you are born, you are basically spending down that reserve.
Right.
But before we can even talk about how to track that progression, we kind of have to establish what chronic kidney disease actually is clinically.
Let's do it. What's the definition?
So, according to clinical guidelines, it's defined as abnormalities of kidney structure or function.
Okay, kind of broad.
Yeah, but practically speaking, that usually means looking at your glomerular filtration rate, or GFR.
And that's just a measure of how much blood your kidneys can filter per minute.
Exactly. And usually a GFR dropping below 60 is the trigger. Or it could be the presence of, physical damage markers. So if protein is leaking into your urine, which is called albuminuria.
Right.
But, and this is a massive caveat, whatever abnormality is happening, it must be present for 3 months or longer.
Okay, let's unpack this right here.
Yeah.
Because I feel like in a lot of diseases, a time frame like 3 months is just, an arbitrary line drawn in the sand for insurance coding or something. Why is that 3-month rule the whole ball game here?
That is a great question, because in nephrology, that time frame is the absolute defining line between a temporary crisis and a permanent reality.
Oh, wow. Okay.
Right. So if your kidneys suddenly shut down because you got severely dehydrated, or maybe you had a really bad toxic reaction to a medication over a weekend.
Which happens.
It does.
Yeah.
That is acute kidney injury, or AKI. Your filtration rate might just completely plummet. But with IV fluids and some time, maybe in a few days or a couple of weeks, those cells can recover.
So the filtration bounces right back up.
Exactly, it bounces back. However, if that decreased function persists for 3 continuous months, that tells us the tissue isn't just stunned.
It's gone.
It is scarred over. It is permanently destroyed.
It's like the difference between, a stalled engine that just needs a jump start and an engine where the metal has completely rusted through.
That is a perfect analogy, yeah.
But to really understand how doctors track this slow rusting today, we have to look back at how chaotic the medical landscape used to be, right? Because from our sources, before 2002, there was no standard way to talk about this early, slow loss.
Oh, it was essentially the Wild West of diagnostics.
Oh, Wild West.
Truly. Nephrology simply didn't have a shared standardized language for early kidney disease.
So doctors were just using these vague, interchangeable terms like chronic renal insufficiency or chronic renal failure or mild renal impairment.
Which means absolutely nothing specific.
Right, which meant that you could go to one clinic, a doctor looks at your lab results and labels you as a sick patient with kidney disease.
Yeah.
Then you drive across town for a second opinion. That doctor looks at the exact same numbers and says, oh, you're relatively healthy, you just have a little mild impairment.
Exactly. And you can imagine the ripple effects of that chaos. I mean, if primary care doctors can't agree on who actually has the disease, researchers certainly can't compare their clinical trials to figure out how to treat it.
Obviously not. You're comparing apples to oranges.
Right. So in 2002, there was this massive intervention. The National Kidney Foundation convened a group called the KDO-QI Work Group.
KDO-QI, right.
Yes.
No.
Chaired by Dr. Andrew S. LeVay. And they basically stepped in to force a standardized vocabulary on the medical community. They introduced a strict 5-stage system based entirely on estimated GFR.
Wait, I have to challenge that. You're telling me an entire diagnostic system for millions of people wasn't based on some like sudden breakthrough biological discovery.
Nope.
It was just a committee sitting in a room and drawing arbitrary lines in the sand.
Yeah.
How did the medical community accept that without a complete revolt?
Oh, well, there was pushback, absolutely.
I bet.
I mean, anytime you take a smooth, continuous biological decline and artificially chop it up into distinct stages, you're going to get friction.
Right, because biology isn't stepping stones, it's a ramp.
Exactly. But the medical community ultimately accepted it because the alternative was just so much worse. They desperately needed actionable mile markers along that attrition curve.
Just to have a shared language.
Yes. And we need to talk about what's actually driving that attrition. For about 2/3 of all cases in the developed world, it comes down to just two culprits.
Diabetes and hypertension. High blood sugar and high blood pressure.
Right.
And both of those diseases essentially act as like mechanical and chemical wrecking balls to the nephrons.
That's a great way to visualize it.
Yeah.
So inside each of those million nephrons is a microscopic tuft of capillaries. It's called a glomerulus.
Okay, the glomerulus.
And if you have chronic high blood pressure, you are basically blasting high-pressure fluid through delicate vessels that were simply not designed for it.
Oh, man.
So the vessels stretch, they scar, and eventually they just collapse.
And then with diabetes.
With diabetes, the high blood sugar makes the blood literally stickier and highly inflammatory, which thickens and damages the vessel walls until they just can't filter anything at all.
But I mean, if we know exactly what causes it, and we have this established 5-stage system based on a blood test that literally any primary care doctor can run.
Right.
Why is this disease still caught so late? Why are people showing up in emergency rooms needing dialysis when we've been tracking these stages for decades?
Because that brings us to one of the most remarkable and frankly dangerous facts about human anatomy.
Which is?
The hidden functional reserves.
The hidden functional reserve. Wait, let me make sure I'm hearing this correctly from the source material. You're saying a patient can be actively losing hundreds of thousands of nephrons and their routine physical would still say they're perfectly fine.
Yes, absolutely. You can lose up to 50% of your total nephrons before standard blood tests show a drop in your overall kidney function.
Up to 50%. How is that even biologically possible? I mean, if half the filters are gone, the filtration rate should instantly drop by half, right?
You would think so, but it's because the surviving nephrons compensate.
Right.
They undergo something called hyperfiltration. Think of it like a massive multi-lane highway.
Right, I'm with you.
If there's an accident and 3 lanes are suddenly closed, the traffic doesn't just stop. The remaining open lanes have to absorb all of those cars.
Oh, I see.
So the traffic speeds up, the friction increases, and the sheer volume of pressure means the pavement in those remaining lanes is going to degrade and crumble much faster than it normally would.
Wow. So the surviving nephrons are physically swelling and like increasing their own internal pressure to take on the workload of the dead ones.
Exactly.
They're literally destroying themselves just to keep the overall blood chemistry looking stable on a lab test.
That is exactly what's happening. And because of that hyperfiltration, chronic kidney disease is a completely silent disease until quite late, usually stage 4.
Which busts a huge misconception. People assume that if their kidneys are failing, they'll feel sick.
Right. They think their back will hurt, or they'll have trouble urinating, or they'll feel nauseous.
But they don't. You could be in stage 2 or stage 3, walking around feeling totally fine.
Completely asymptomatic, which means we are entirely reliant on the math of these blood tests to catch it early.
But even the basic blood test is highly misunderstood, isn't it? I mean, when people get routine labs, they usually look at their creatinine level.
Yes, serum creatinine.
And creatinine is just a natural waste product from normal muscle breakdown, right? And healthy kidneys filter it out. So if your kidneys are failing, creatinine builds up in your blood. It seems like a pretty straightforward metric.
Well, it seems straightforward until you account for human diversity.
How so?
Let's look at the mechanics of creatinine. Because it's a byproduct of muscle mass, the raw amount of creatinine in your blood is heavily dependent on how much muscle you actually have.
Oh, right. So if you take a 25-year-old bodybuilder who lifts weights 3 hours a day, and then you compare him to an 85-year-old frail woman who is mostly sedentary, they have vastly different amounts of muscle tissue generating that waste.
Precisely. So if we just look at the raw creatinine number, they might have the exact same level in their blood.
Really?
Yes. But for the bodybuilder, that's just because he has massive muscles constantly generating waste, and his kidneys are actually working perfectly to clear most of it.
Okay, but for the elderly woman?
For her, she barely has any muscle mass to generate waste. So if her creatinine is reaching that same high level as the bodybuilder, it means her kidneys have almost completely stopped filtering.
Wow. Which is exactly why you can't just look at the raw number on a lab sheet. You have to use those complex equations we mentioned.
Right, the estimated GFR or EGFR.
You have to adjust for age and sex and body size to figure out what the kidneys are actually doing.
Exactly. And as our understanding of this disease evolved, the medical community realized that even the EGFR wasn't telling the whole story.
So they changed it again.
Yeah, which led to the creation of the modern heat map. In 2012, a global kidney organization called KDOGO updated those original 2002 guidelines.
Okay.
They kept the 5 GFR stages, but they added a second axis to the chart: albuminuria.
All right, albumin. That's a protein in the blood. And from what I read, in a healthy kidney, it's just too big to pass through the microscopic filter into the urine.
Correct. It's like trying to push a bowling ball through a screen door.
Good luck with that.
Right. So if albumin is showing up in the urine, it means the physical structure of the nephron filter is actively tearing.
So KDOGO categorized this leakage, right, from A1 to A3.
Yes, because research showed that leaking protein is a massive predictor of kidney failure, completely independent of what your filtration rate is.
It's a structural warning sign.
Exactly. So now doctors use a grid. They cross-reference your GFR with your protein leakage to assign a color-coded risk level: green, yellow, orange, red, and deep red.
And this heat map totally explains why stage 1 CKD is so unique. Well, in stage 1, your GFR is completely normal,
Right.
90 or above. The filters are keeping up with the traffic.
Right.
So the only way you could even be diagnosed with stage 1 is if those early damage markers like albumin are showing up. The structural damage has started, even if the overall filtration rate hasn't dropped yet.
That is spot on. But, once that hidden reserve finally runs out and the GFR starts dropping into stage 3 and stage 4, the damage refuses to stay confined to the kidneys. It triggers a really devastating systemic domino effect.
Because the kidneys don't just act as passive filters, right? They are active chemical managers for the entire body.
They do so much more than just make urine.
So what does this all mean? Let's look at the cascading failures, starting with the bones, which I found fascinating in the sources. When your filtration rate falls below, say, 45 or 50, the kidneys begin to fail at 2 vital jobs.
Right, activating vitamin D and excreting phosphate.
It is a textbook example of how one failing organ takes down the whole neighborhood.
It really is. When your kidneys can't excrete phosphate, it builds up in your blood. And at the exact same time, because your kidneys aren't activating vitamin D, your gut basically stops absorbing calcium from your food.
So your blood is suddenly high in phosphate and critically low in calcium.
Exactly. And your body detects that imbalance and completely panics.
Because calcium is important for, everything. Heart rhythms, muscle contractions.
Everything. So the rising phosphate triggers your parathyroid glands, these 4 tiny glands in your neck, to go into overdrive.
Okay.
They start pumping out massive amounts of parathyroid hormone. And the primary emergency job of that hormone is to find calcium and bring it into the blood to restore the balance.
But wait, if you aren't absorbing it from your food because of the vitamin D issue,
Yeah.
where does the hormone get it?
It goes to the body's largest calcium vault.
The skeleton.
It pulls it straight out of your bones.
It literally robs your skeleton.
It relentlessly leaches calcium from your bones, a condition called renal osteodystrophy. Your bones become structurally hollow, they fracture easily, but the tragedy doesn't actually stop with the bones.
Because where does all this stuff go?
Exactly. Now you have all this extra calcium and phosphate floating around together in your bloodstream, and they physically bind together to form calcium phosphate crystals.
And those microscopic crystals, they don't just dissolve, do they?
No, they don't.
They get deposited directly into the walls of your blood vessels.
Right. You are quite literally calcifying your own cardiovascular system from the inside out. Your flexible arteries turn into rigid, stiff pipes.
Which explains one of the most profound shifts in how medicine views this disease.
Yeah.
Back in 2004, the New England Journal of Medicine published this landmark study by Go and colleagues. They looked at over 1 million adults, and what they found completely disrupted the narrative.
It really shook the field.
They proved that as GFR declines, your risk of cardiovascular death spikes astronomically.
It's a very sobering clinical reality. For the vast majority of patients with moderate CKD, the dominant cause of death is a massive cardiovascular event.
Like a heart attack or a stroke.
Yes. And that happens long before they ever progress to end-stage kidney disease requiring dialysis.
So wait, they die of a heart attack before their kidneys actually fail.
Usually, yes.
That reframes the entire condition. We think of it as a kidney problem, but it's really a whole body vascular disease. The kidneys are just the first domino.
That is exactly how nephrologists counsel patients today. When you're in stage 3, the clinical focus has to be on aggressively protecting the heart, just as much as saving the remaining nephrons.
But, okay, if this EGFR number is dictating everything,
Right.
if it tells a doctor your heart attack risk, if it decides whether you get referred to a specialist, or if you can get put on a kidney transplant wait list, the math behind it has to be completely bulletproof.
You would hope so.
But it wasn't, was it? For a long time, these equations were actually the center of a massive medical and ethical controversy.
Yes, this is a critical piece of modern medical history. For nearly 2 decades, the standard EGFR equations used in laboratories worldwide, like the MDRD equation, and later the CKD-EPI, they included a specific race correction factor.
A race coefficient.
Right. If a patient was identified on their chart as Black, the algorithm automatically multiplied their estimated GFR by roughly 1.16 to 1.21.
Meaning the math literally output a higher, healthier-looking kidney function number for a Black patient compared to a non-Black patient who had the exact same raw creatinine blood test results.
Correct.
So to look at this impartially, what was the original rationale for doing that?
Well, the original clinical rationale was based on early cohort studies that suggested Black populations, on average, had higher measured creatinine generation.
Which they tied to muscle mass.
Right. Researchers at the time hypothesized it might be tied to differences in average muscle mass. So the algorithm was an attempt to mathematically adjust for that to get a more accurate estimate of true biological filtration.
But the criticism of that approach was intense.
Oh, absolutely.
Because it assumed that race, which is, largely a social and cultural construct, was a concrete, universal biological variable that you could just plug into a chemical equation.
Yes. And the real-world consequences of that math were severe. Because the algorithm artificially inflated the apparent kidney function of Black patients, it made them look healthier on paper than their kidneys actually were.
Oh, wow. So what did that mean, practically?
It meant they crossed the clinical thresholds for specialist care and transplant waitlist eligibility months or even years later than white patients with the exact same lab values.
Years later.
Yes. It was a mathematical function that actively delayed life-saving care.
It's staggering to think about a background laboratory algorithm having that kind of power over human lives, just sitting there on a lab printout.
It really is. But after years of sustained advocacy and really rigorous debate within the medical community, in 2021, a joint U.S. task force formally recommended retiring the race coefficient entirely. A new race-free equation was adopted by U.S. labs. It's a rare instance in medicine where a deeply embedded diagnostic formula was overthrown and retired, not just for statistical recalibration, but because of its real-world systemic impact.
That is incredible. But, that actually isn't the only debate over how we calculate who has this disease. Here's where it gets really interesting.
The aging debate.
Yes. There's a massive controversy regarding the elderly, because we know that your glomerular filtration rate naturally declines as you age just through cellular senescence.
Right. The nephrons simply age, just like your skin or your joints.
So a healthy 20-year-old might have a GFR of 120, but by the time they were 80, even without diabetes or hypertension, their GFR might naturally drop to 55, just from the normal wear and tear of living for 8 decades.
That's entirely possible, yes.
So if the hard diagnostic cutoff for stage 3 CKD is a GFR of 60, aren't we taking an 80-year-old with a GFR of 55, pointing at them and saying, you have a chronic disease?
That is the big question.
Aren't we just pathologizing normal human aging? We're causing unnecessary anxiety, maybe changing their medications, sending them to specialists, all for something that is entirely natural.
You've just summarized a major debate in geriatric nephrology right now. Is it overdiagnosis?
Yeah.
But KDI Go, the guideline organization, has a very firm counterargument, and it's rooted in the data.
Okay, what's their defense?
They point out that even if a GFR of 55 is normal for an 80-year-old in the sense that it is statistically average for their age group, that lower filtration rate still carries a measurably elevated cardiovascular risk.
Really?
Yes, and a much higher risk of drug toxicity.
Oh, because their kidneys can't clear the medications out of the bloodstream as quickly. So a normal dose could become a toxic dose.
Exactly. So KDI Go argues that giving it a formal diagnostic label of CKD is clinically vital because it waves a red flag for the physician.
A warning label.
Right. It tells them to monitor the heart closely, to lower the dosages of standard medications so toxins don't build up, and to avoid prescribing certain drugs altogether that could push those fragile aging kidneys over the edge into acute failure.
So even if the decline is natural, it is still dangerous enough to require that warning label.
That's their stance, yes.
When we zoom out from these clinical debates and look at the sheer scale of the disease, it is staggering.
It is a public health crisis operating entirely in the background. Because CKD tracks alongside the massive modern epidemics of type 2 diabetes and hypertension, the numbers are just astronomical.
Let's hear them.
According to public health data, roughly 1 in 7 adults in the U.S. currently has chronic kidney disease.
1 in 7 adults. And because of that hidden reserve and the hyperfiltration we talked about earlier, the vast majority of the people walking around in stage 3 have absolutely no idea they are slowly losing their nephron budget.
They are completely asymptomatic, and the societal and economic cost of this silent progression is unparalleled.
I really want to highlight the economics of this, because it led to one of the most unique healthcare policies in American history.
The 1972 Medicare carve-out.
Yes. So dialysis, which is the mechanical treatment you need when you reach stage 5 and your kidneys completely fail, is unfathomably expensive.
Yes.
Back in 1972, when dialysis machines were relatively new, incredibly scarce, hospital committees, sometimes they were literally called God panels, were deciding who lived and who died based on who could afford it and who had access.
It was an ethical nightmare. The financial burden of dialysis would instantly bankrupt almost any individual family.
So in 1972, the U.S. government under Nixon created a completely unique universal coverage carve-out.
Right. Medicare covers end-stage renal disease for dialysis regardless of your age.
Regardless of age.
If your kidneys fail, the government pays for the treatment.
It is one of the only disease-specific universal coverage policies in the country, and it underscores just how critical it is to prevent progression in the early stages, because the sheer amount of resources required at stage 5 is monumental.
Which means we really need to correct one final major misconception here.
Oh, about dialysis being a cure.
Yes. People hear about dialysis and they view it as a cure. They think you go to the clinic, they hook you up to the machine washes your blood, and you go home functioning at 100%.
Like getting an oil change for your car.
Right, but dialysis is absolutely not a cure. It is an incredibly exhausting, grueling mechanical process where your blood is pumped out of your body, pushed through a synthetic filter membrane, and pumped back in.
Yeah, even running perfectly.
Even running perfectly, dialysis only replaces about 10 to 15% of your normal, healthy kidney function.
10 to 15%. It just barely clears enough toxins to keep you alive.
Barely. It manages the most severe symptoms, but you are still living with profound physiological deficits. It does not restore the kidney tissue, it doesn't activate vitamin D, and it doesn't regulate your blood pressure hormones effectively.
Right, all those systemic things we talked about.
The only clinical intervention that even approaches normal function is an organ transplant, which is why kidneys make up by far the largest share of the transplant waitlist globally.
Which brings everything we've talked about right back to you, the listener. The reason we are diving into the mechanics of this disease isn't just to memorize clinical stages or understand the history of medical algorithms.
No, not at all.
It is about understanding the biological budget you possess right now. Those million microscopic filters in each kidney are taking the physical brunt of every prolonged blood pressure spike and every chronic blood sugar elevation.
Every single one.
Protecting those tiny capillary tufts early on, before the hidden reserve runs out and the highway collapses, is quite literally the only way to safeguard the nephron budget you were born with.
It is entirely about recognizing the silent, invisible damage before the physical alarm bells finally ring. And, if we connect everything we've unpacked today, from the silent hyperfiltration to the complex debates over how we diagnose the elderly, it leaves us with a really profound question to consider regarding our own health.
Oh, I like this. What if the way we define normal aging is really just our failure to differentiate between inevitable wear and tear and preventable disease?
Exact.
How much of what we accept as simply getting older, the fatigue, the stiffness, the vascular changes, is actually a silent systemic decline that we could have caught and slowed down years earlier with a simple blood test?
A slow loss of filtration hiding in plain sight.
You start with 1 million filters per kidney. The goal is to hold on to as many as you can for as long as you can.